Hello everyone, today we'll be introducing EHR. Our group members are Lin Yousun, Peng Zifang, and Wu Yangting.
First of all, what is EHR? EHR is the abbreviation for Electronic Health Record. As the progress of technology, filing medical record in electronic form is proved much more supportive in many points of a medical care workflow. Therefore, it almost replaced paper record and became the general practice nowadays. First, we will introduce differences between an EHR and a paper record. Then we will move on to other introduction and discussion. First, we talk about differences between paper record and electronic health record. Input of data can be simplified by using existing text sets or ways that can be recognized by computer, such as codes. An EHR also accepts many formats as input. As well as input, an EHR can also display data in many different formats according to local customs. An EHR system can suggest corrective actions by comparing with population of patients or by analyzing patient's condition. It can also call attention to trend and dangerous conditions. Accessibility means that an EHR system can be accessed by more than one user at the same time, which is a function that paper records do not have. There are 5 functional components in an EHR system, which may be encountered by users during workflow. Providing an integrated view of patient data is the ultimate goal of an EHR. An integrated EHR must include a broad spectrum of data types, such as numbers, texts, images, and videos. By using EHR systems, clinicians' orders can be passed in digital forms directly to the recipients, reducing errors when transcribing from a paper form to another. The providing of decision support from an EHR is best delivered when patients come to care site for other reasons like routinely visit or during the physician order entry process, for it is the only point in a workflow at which to discourage or countermand an order that might be dangerous or wasteful. Selection of knowledge is rich for clinicians today. Some of the information are publicly available and can be accessed anytime and anywhere. Since most of clinical questions are asked in the context of a specific person, an appropriate time to offer knowledge is when physicians are writing notes or orders, and the linking between knowledge source and EHR is made for completing the task. Efficiency and effectiveness of communication among multiple health professionals and many organizations are very important since the delivery of patient care requires such team members and organizations increasingly. The application of such concept helps a lot when patients handoffs and when timely response by clinician is necessary. EHR use 2 general methods for data capture. First, electronic interfaces from systems, and the second, direct manual data entry. The preferred method of capturing EHR data is to implement an electronic interface between the edge EHR and the existing electronic data source, such as laboratory system and pharmacy systems. Data can also be typed in by people, which is a manual data entry. When done so, data may be entered as narrative-free text or as codes. Statistics shows that physicians spend about 20% of their time documenting the clinical encounter, which brings up the question, should physicians always enter data by themselves? Many believe that clinicians themselves should enter all of these data directly into the EMR under the assumption that the person who collects the data should enter it. However, always follow this rule is not efficiency. Physicians' notes can be entered into the EHR via one of 3 general mechanisms: transcription of dictated or written notes, transferring and coding of data by clinic staff, and direct entry by physicians. Once stored in a computer, data can be presented in numerous formats, such as timeline graphs, timeline flowsheet, summaries, and snapshots, for different purposes.
After knowing the features of EHR, it is also important that we understand how EHR are being used in hospital. That is, the application of EHR or how EHR link up hospital departments.
In a hospital, each personnel is given a set of account and password when he or she takes office. All accounts were set into different levels of authorities depending on the position of the personnel, making some information available only to authorized ones. Health records including sensitive data such as sexual assault or domestic violence, or those belongs to VIP patients, are only available to specific personnel. Medical records will be managed by the medical record department and, as same as its electronic form, allows retrieval by specific personnel only. Some VIP patients may also request that his or her medical record to be in paper form only. In an EHR, diagnosis or nursing records are typed in mainly by physician or RN. Correcting and changing of any record can only be done by the original creator. Corrected content will only be crossed out but not deleted. Also, any browsing history and correction will be recorded. For medical record numbers, each patient will have only one medical record number in one hospital. If a patient forgets about having gone to the same hospital before or sent emergency anonymously, a new medical record number may be given until the hospital finds out the previous medical record of the same person.
Electronic health record system for large integrated healthcare delivery network today are often viewed as monolithic, flexible, difficult to use, and costly to configure. They are almost always obtained from commercial vendors and require considerable time, money, and consulting assistance to implement, support, and optimize. The most popular systems are often built around older underlying technology, and it often shows in their ease to use. Many healthcare providers find this system complex and difficult to navigate, and it is rare that the EHR system is a good fit with their preferred care delivery process. As delivery networks grow and deploy broad enterprise EHR platform, the challenge of making them help rather than hinder clinicians is increasing. Clinicians' knowledge extends far beyond their clinical domain. Care procedure knowledge, patient context knowledge, administrative process knowledge, and it's rare that EHR can capture all of it efficiently or make it easily available. What's more, in the US, regulatory, billing, and revenue cycle requirements add additional complexity to the electronic healthcare workflow and further reduce the time clinicians have to engage with patients. The options for improving this misalignment between system and processes are limited. One is to design EHR system to be more integrated and streamlined from the beginning. One Medical, for example, a concierge medical practice across 40 cities in the US, developed its own EHR system that is closely aligned with the care and patient relationship practice its employees. Flatiron Health, a data and analytics-driven cancer care service recently acquired by Roche, but a company with a web-based EHR and tailored it to fit its OncoCloud EHR for community-based oncology. Although these bespoke systems do seem to fit clinicians' workflow better, they are themselves difficult at time conclusion to develop, and they are relatively narrow in scope. Building a system from scratch or extensively customizing a commercial one would be probably not work for large delivery network. Using an open source EHR is a second option. However, most current ones are designed for small medical practice and aren't easily scalable or need substantial configurations. And even though the software is free, considerable programming and IT infrastructure is required to implement it and tailor it to the individual practice. Further, open source EHRs are less carefully maintained and less frequently updated than commercial ones, and so can quickly become obsoleted. Finally, regulatory requirements and reimbursement rules change rapidly. Rely on either open source or internally developed systems, and keeping up with those requirements creates both compliance risks and financial challenges. A third and more promising option is to use AI to make existing EHR systems more flexible and intelligent. Some delivery networks, sometimes in collaboration with their EHR platform vendor, are making strides in this direction. AI capabilities for EHRs are currently relatively narrow, but we can expect them to rapidly improve. They include data extraction from free text, diagnostics and/or predictively algorithms, clinical documentation and data entry, clinical decision support. And now first we're going to talk about the data extraction from free text. The providers can already extract data from faxes at One Medical or by using Athena Health EHR. Flatiron Health human extractors review providers' notes and pull out structured data, using AI to help them recognize key terms and uncover insights, increasing their productivity. Amazon Web Services recently announced a cloud-based service that uses AI to extract and index data from clinical notes. Diagnostic and/or predictive algorithm. This talking about Google is collaborating with delivery network to build prediction models from big data to warn clinicians of high-risk conditions such as sepsis and heart failure. Google, Analytics, and a variety of other startups are developing an AI-derived image interpretation algorithm. Clinical documentation and data entry is talking about the capturing clinical notes with natural language processing allows clinicians to focus on their patients rather than keyboards and screens. Nonce offer AI-supported tool that integrated with commercial EHRs to support data collections and clinical note compositions. The last part that included is clinical decision support. Decision support, which recommends treatment strategies, was generic and rule-based in the past. Machine learning solutions are emerging today from vendors including IBM, Watson, Change Healthcare, Allscripts that learn based on new data and enable more personalized care. Well, AI is being applied in EHR systems principally to improve data discovery and extraction and personalized treatment recommendations. It has great potential to make EHR more user-friendly. This is a critical goal as EHRs are complicated and hard to use and are often cited as contributing to clinician burnout. Today, customizing EHRs to make themselves easier for clinicians is largely a manual process, and the system rigidity is a real obstacle to improvement. AI and machine learning specifically can help EHRs continuously adapt to users' preference, improving both clinician outcomes and clinicians' quality of life. However, all of these capabilities need to be tightly integrated with EHRs to be effective. Most current AI options are encapsulated as standalone offering and don't provide as much value as integrated one and require time-pressed physicians to learn how to use new interfaces. But mainstream EHR vendors are being to aid AI capabilities to make their system easier to use. Firms like Epic, Sensor, Allscripts, and Athena are adding capabilities like natural language processes, machine learning for clinical decision support, integration with telehealth technologies, and automatic image analysis. This will provide integrated interface access to data held within the systems and multiple other benefits, though it will probably happen slowly. Future EHRs should also be developed with the integration of telehealth technologies in mind. As healthcare costs rise and new healthcare delivery methods are tested, home devices such as glucose meter or blood pressure cuffs that automatically measure and send results from the patient's home to EHR are gaining momentum. Electronic patient report outcomes and personal health records are also being leveraged more and more as providers emphasize the importance of patient-centered care and self-disease management. All of these data sources are most useful when they can be integrated into the existing EHRs. Most delivery networks will probably want to use a hybrid strategy, waiting for vendors to produce AI capabilities in some areas and relying on third-party or in-house development for AI offerings that improve patient care and the work lives of providers, starting from scratch. However, is probably not an option for them. However, necessary and desirable, it seems likely that the transition to dramatically better and smarter EHRs will require many years to be fully realized.
Finally, I'm talking about EHR application using in smart hospital. First, I'm introducing how EHR integrate with predict system. Chime Hospital predict outcomes in older emergency department patient with influenza in real time using a big data driven and machine learning approach to the health record. We can see there is a button called disease prediction. When the doctor clicks the button, the system will show some probabilities when the patient has already had influenza. Second, I'm introducing the application called Matrix Care. Matrix Care is a post-acute EHR software solution. It is the application of EHR in long-term care. Matrix Cares help operators streamline their processes to drive occupancy and meet business objectives. By leveraging innovative technology, it enables staff to manage financial and operational information using just one cloud-based system. That brings me to the end of our presentation. Thanks for your attention.